There's a quiet complexity in our genes, a missing piece, a twisted strand, or a chromosome that loops into a circle. These tiny errors, invisible to the eye, can shape an entire life. Today on Willow Lifeline Dialogues Code of Life series, we're exploring one of those rare but profound conditions, ring chromosome 18. It's not well known, even among many healthcare workers, but for the families affected, it brings a lifetime of questions, adaptations, and sometimes silence from the very healthcare system. Christine got a call that said her daughter had Down syndrome, but was it? She went online only to find out that she was dealing with something totally different. Here is Christine's story.
It's a diagnosis that arrived quietly but changed everything. One small genetic difference and a mother's entire life was rewritten. This is the story of a mother who left behind her lucrative career to care for her daughter with a rare anomaly on chromosome 18, a woman raising awareness and a child in a world that still doesn't understand rare.
When I was in the office and this physiotherapist calls me and tells me that I think your child has Down syndrome. So I'm like, okay. I didn't ask him where that came from. It was rather sudden, but I said, given that her big sister has a rare condition, I'm not going to chance it. That afternoon, I didn't work. I just looked for symptoms of Down syndrome. How do they look like, facial features, all that.
A test called chirotyping confirmed it, a rare chromosomal difference on the 18th chromosome.
I remember the results came back to me because I'm the one who went to the lab with a request and gave out my email, and it came back positive for chromosome 18 anomaly. And I remember them telling us at the bottom of the paper, genetic counseling recommended.
Chromosome 18 anomalies are part of a spectrum. Some children are mildly affected. Others, like Christine's daughter, live with multiple conditions such as hypothyroidism, hypertension, kidney disease, and diabetes. She now sees 3 specialists regularly. Each visit is a cost and a reminder.
Taking care of a medically fragile child or a complex medical condition entails a lot in Kenya because most doctors don't know what they're dealing with. You get to see different specialties of doctors. You get admitted and they have an idea what you're talking about. So actually, personally, what I did, I have 2 folders, each for each child with their medical history, their conditions, their lab results, what pertains to which doctor. The younger one has medicine, so what medicine she's taking up to date dosages.
The cost of care is immense, and not just emotionally. Christine couldn't get insurance to cover congenital conditions. She couldn't find schools willing to accommodate her children, and eventually, she left her job to become a full-time caregiver.
Okay, when my firstborn was born, I remember she had congenital hydrocephalus, and insurance refused to cover that because they said it's congenital. And fast forward to my second-born, and has this chromosomal, so that's even worse. There's no way they're going to cover that. And it's sad because at least nowadays I see that insurance covers it, but only to a very minimal capping that doesn't make a difference as compared to the premium that you're paying. And you can't, like for myself, for example, I can't take a family insurance. My premium will be like so high because I have 2 kids with different rare conditions. I remember there's a time when I was trying to school them before COVID, in their younger years. I couldn't get schools.
That fight birthed something more. Christine, a co-founder for Rare Disorders Kenya, a patient-led organization now collaborating with the Ministry of Health, working on policy research and compassionate access to treatment for rare conditions.
Now we have an organization that actually deals with people living with rare diseases. And awareness is not only once a month. And we're doing more than just awareness. We are improving the lives of our members, we are researching, we are collaborating with different stakeholders, including MOH. And for me, that seed that started when I was grasping straws for my kids, I think beats any degree that I would have done or have ever done. And what I do now gives me purpose in life.
As Kenya joins global calls to recognize rare diseases, families like Christine's are already doing the work. One diagnosis at a time, one folder at a time, one fierce, relentless mother at a time.
The resolution for rare diseases was actually passed. It was adopted, and what the WHO's resolution for a rare disease means is that member countries will have to put that in their budget. And for us, I think that is the best thing that could have happened. And to think that RDK was part of the campaign for that resolution is even more exciting, because we feel like we are part of history making.
As the world begins to listen, mothers like Christine have already spoken, with action, with advocacy, and with love. The path ahead is still unmarked, but thanks to voices like hers, it's no longer walked alone. For Code of Life, I'm Sarah Kamande.
With me now to discuss all this is Dr. Catherine Mutinda, a pediatrician and geneticist who has supported many families facing such rare and complex genetic disorders. Today, she helps us understand what happens when chromosome 18 is abnormal and how that subtle shift changes everything. Karibu sana, Dr. Mutinda. Welcome to Code of Life again. Thank you for taking time to really help us discuss these rare but conditions that impact lives, not just for the families, but also the children who are born with this. And so today we'll start, as we always do, from the basics. When our audiences hear chromosomes, trisomy, monosomy, all of these things sound very big, very medical jargon and all of that. So what is ring chromosome 18 and how is it different from, say, a trisomy, monosomy, I don't know, deletion, microdeletion, all of these complex terms?
Okay. So as you said, that we should start from the beginning. So let's start by understanding that we have a code called DNA. We all are together on the DNA. Mm-hmm. So DNA has to be packaged. So how do we package letters? We package them in an envelope. So imagine you're in a post office, and then this post office 1 all the way to post office 23. Mm-hmm. So label your post offices number 1, 2, 3. So that's how our DNA is packaged in these envelopes. Mm-hmm. Number 1 all the way to number 23. So each number 1, there are 2 envelopes. Mm-hmm. Number 2, 2 envelopes, all the way to number 23. Number 23 is a special box. It is the one that decides whether you are a boy or a girl. So 23 can have 2 envelopes written X for a girl, or 2 envelopes written X and Y for a boy. So all our post office boxes have these packagings called chromosomes. So these envelopes are chromosomes. Mm-hmm. And inside them is where we carry our DNA. Mm-hmm. So when we have chromosome 1, 2 envelopes carrying all the DNA in chromosome 1, mm-hmm. it means all the important information that chromosome 1 is supposed to do is in those 2 envelopes. Mm-hmm. So when I want to read the envelope, I open one envelope mm-hmm. and the second envelope. Mm-hmm. So in our case, where we have a ring chromosome 18, it means as my envelopes are supposed to lie flat, mm-hmm. this one envelope has decided to be a circle mm-hmm. instead of being a stick. Mm-hmm. So what will happen in my post box? Will my ball fit when it mm-hmm. exactly?
It will be different.
And then which parts of this, which edges have joined? Mm-hmm. So remember, inside the envelope is information. Mm-hmm. So the information has been changed.
So it's like a stick, yes, or even this paper, and yes. I fold it like this instead of having it flat.
Exactly.
Okay.
Yeah.
Okay.
So just to get a bit more complex, so this is what you see in the peripheral blood. So we are supposed to have sticks, and they're supposed to be 23 sticks. However, as humans, we also have another set of DNA called the mitochondrial DNA. Now, the mitochondrial DNA sits in circles. Yes, it's not linear. So when we see a circular chromosome outside the mitochondria, there's a problem because the cycle is holding, there's somewhere that it's touching each other. And remember, at the end of this chromosome, so that they are equal distance, they have to be protected so they don't touch each other. So something is also lost for them to touch each other. Yes.
Okay. So when somebody has this ring, but even before we go to the symptoms, is that the only thing that affects chromosome 18, or are there other
There are many
issues?
things. Our chromosomes are complex, just like God is complex, and everything is decided by Him. So, number one is supposed to have loads of genes. And number two, all the way. So when you look at what we call a simple picture of our DNA, you will see that the number ones are the largest, and then number 23, and that's the X and the Y. The Y is a bit smaller, it's a bit bigger, but 22 is teeny tiny, 21 tiny, tiny, like that. So they actually represent how much they are carrying inside them. Yeah? So each one of them, they're supposed to come in as doubles,
Pairs,
as a pair. But we all know sometimes they can decide to come in singular. That's what you call the monosomy. Or they come in threes.
The trisomy.
And then a more interesting part, they decide we would be completely three. Just a part of us becomes three, or a part of us lessens. So microdeletions, microduplications. And to make it even more interesting, we have instabilities within the chromosome. So it's supposed to arrange itself like reli kutoka Nairobi mpaka Nanyuki. There are stops in between. And then the stops start interchanging each other. Yes.
Okay.
So there are so many things that happen in there.
So when this happens, obviously we can't see this with the naked eye. So what symptoms and signs do we see in a child or in somebody, say with ring chromosome 18?
So let's start by the fact that there's the way we expect a human being to look like. Our grandparents will come and check your ear and say, huyu ni wetu. Right? So the ear seems to be very important even for the African community. So it is for the geneticists. So we start with, how is your ear placed in relationship with your eyes? How is your nose placed in relationship with your eyes? How is your nose placed in relationship with your mouth? How are you looking like? Do you have all the features we want you to have? Do you have 3 eyes or 2 eyes or no eye? You understand? So we look at something we call morphology. What do we see? Are they where they're supposed to be for most humans? So you have patients who have extra digits, which a lot of people just cut off. You understand? The others who have fewer digits. What happened? So all these things are the things that actually spring out at birth that tell people, oh, something is off with our chromosomal packaging. Yeah.
So what are these signs and symptoms for somebody with a ring chromosome 18?
So I will not stick to a ring chromosome 18.
Okay.
We usually say chromosomal anomalies will give you dysmorphic features. Now, dysmorphic features, they are those we call farm handles, which everybody will say, you've seen a child with Down syndrome, their eyes look like pears, their ears are low set. Those are called firm handles. They have high arched palates, but there are some handles that are not firm. Like you'll hear about the single simian crease. The normal population have people who have single simian creases. And they don't have
simian crease?
It is just these lines in our hands, and you have 3 of them. Some of them just have one. Yes? So that's
not normal.
That's not normal. You find it a lot with people with Down syndrome, but you also find it with people without any trisomic issues. So the first thing is to notice what is the norm and how far from the norm the child looks. So the baby is born, and there is what we say the first examination. So the first examination looks at the proportionality of every of the organs, especially on the head, the hands, the body, everything. So when we look at that, then we say, oh, there's something that doesn't look proportional. So most of the time it is aneuploidy. So we don't say it's chromosome 18, 19, whatever. We say aneuploidy, a chromosomal anomaly. And because, as you earlier said, we can't see the chromosome. So we have to take a test for us to confirm which of the 23 chromosomes is responsible.
So how do you confirm that there are 23? So do you check all 23 of them, or
Yes.
what do you do?
So with just a blood sample, technically it's a whole blood sample. We usually look at the white blood cells. And in the white blood cells, we actually, if it is a test like a karyotype, we grow the cell in the lab, and then now we ask the cell to start multiplying. And in the multiplication, we stop them at when they are the biggest, and then take a picture. Then we count. Yes.
Okay. So from your explanation, then it seems that every child will have differing symptoms. Everyone will show up differently.
Exactly. And that is why we kind of discourage people from calling it a name at the bedside of the mother until you have a genetic result. And with a genetic result, you are not only able to call it a proper name, but you're also able to give it its symptomatology. Like, this child will have challenges with feeding, this child will have challenges with cognitive, like learning disability, speech disability, all those things you're able to tell, because now you know which part has been affected, and each part is responsible for something. Yes.
So for parents, this journey starts with worry. That feeling that I feel like something is not right. So how can they pick up signs and symptoms that tell them this is more serious than you're taking it, or that feeling of something is not right, you should do something about it? How can they pick that early?
The fact that you feel something is not right is not right. That's simple. I encourage mothers, whenever you feel something is not right, just go tell the doctor, I don't know what's wrong, but I just feel something is wrong. Let us have a conversation around, let's alleviate your fears. You understand? And also, once something is said, and this is to my colleagues, when you say something different, something that tells you there's a chromosomal anomaly, please let the mother know in a conversational, friendly, adaptable way. Let them know, because mothers know. They're waiting for the doctor to say something. And unfortunately, some of us are not trained to have that hard discussion. So let them know and say, I am not the right person to have this discourse with you. I'll send you to someone who can have a discussion with you. Yes? When we see these dysmorphic features, especially as a child, because I'm alone in Kenya, so they are going to be born in Mombasa, Eldoret, everywhere. There are key things we need to look out for. Key things that we call emergencies. Is the heart in place? Because most of them are associated with cardiac diseases. They're not pediatric cardiologists, and I insist pediatric cardiologists, because the pediatric heart is different from the adult heart. So you need someone who's been trained to look at the baby heart, so that they are able to tell you, are there congenital anomalies there? Then the next thing that we are worried about is the thyroid function. Midline, we check. And once those are cleared, we take our time to give it a name, because we know then we need other support systems. For example, you may not get your gross motor development on time, so we need an occupational therapist to support that development. We know about speech, we have enough speech therapists, we know about cognition, we have special schools to place you in. So basically we need to find out early and be able to give the care that's needed.
Okay. So at what stage do you diagnose or give a name? Is it before birth, that is during pregnancy? Is it after the child has come? At what stage would it be best to make that diagnosis?
Best in my dreams, at 9 weeks, please tell the parents. That's the best. I mean, when I get pregnant, I want to know I'm okay. Yes. So we do tests like non-invasive pregnancy testing at that early stage, so that we can know what's going to happen. That they are actually powered to pick these anomalies all the way to around 18 weeks, where you can have an anomaly scan. An anomaly scan done with the right hand in a radiologist's hand, and on top of that, a fetal maternal person, they will not miss. Not that they can't miss, they will not miss most of the time. To tell you we are seeing something that is grossly off the track. There are some salient radiological features, that this baby starts sending signals very, very early, that all is not well with me. Sometimes these babies also start doing, like they just want to left the group. A lot of threatened abortions, and the mother is on bed rest, and a lot of chemicals being used to sustain that pregnancy without necessarily asking yourself, why is this pregnancy trying to terminate itself? Yeah, so those things need to have that discussion. Yeah.
So after, say, during pregnancy, you see those telltale signs, or you've made the diagnosis that this is a chromosomal anomaly. What next?
Inform that patient. Let her have an informed decision. Let her understand what's going on. It's not her fault. She didn't ask for it. So let her know about it. Let her discuss it with her partner. Let her know what her options are. Support each and every decision she makes. If she decides she wants to have that baby, support that decision. If she decides she wants to terminate, support that decision within the legal realms and ethical realms. If she wants to have the baby, now create a conducive environment for that baby to land into. Yes.
What you say, support for the couple, for the mother or the family. What genetic counseling and testing options are there for subsequent pregnancies for a family that has, a child or has had a history of a chromosomal abnormalities, such as this one, of ring chromosome 18?
The first thing, and these are a group of parents who, most of the time you find they've had a lot of pregnancy losses, and they've had then a diagnosis of maybe a trisomic baby or a ring chromosome 18. The first place you should start with them is looking at their own architecture. How is their chromosomal makeup? Most of the time you find they have unstable chromosomes, so a balanced translocation within their genome. So when you find that, they have a propensity of creation of aneuploidies. So the first people to check with is the parents who have either balanced translocation, they're balanced translocation carriers, or there's also an act of nature. You understand?
Just a random
occurrence, yes. But even having said so, the moment that child has been born and has a chromosomal anomaly, it is important for the mother in the next pregnancy to be under the care of a specialist who will actually go through that chromosome anomaly and any other that can happen. Now, you can have one chromosomal anomaly in one child and another in another. So when that happens, lightning doesn't strike twice. There's something off. We need to get into your own genome. We need to get and understand what you are carrying.
So if you check the parents' genetic makeup and you realize they have that instability you talked about, what options do they have for subsequent pregnancies and subsequent children?
So there are many options, and that is why the in vitro fertilization, IVF, is a mode of management and care of these patients. So IVF is not insemination. It is actually treating a group of people who have real genetic risks. So let's say I'm genetically have unstable chromosomes. So I'd like to make my embryos outside me so that I can be very clear that I'm making a child who is viable. Yes? Also, we can talk about donations. You can have an ovum donated, a sperm donation, or we can talk about loving another child, adoption. Yes. So it depends on what the couple wants.
So for these conditions without cure, the journey for families is really about support, adaptation, being resilient. What usually are the goals of care for these children? Because we're not treating, we're not curing. What are the goals that you're looking for when you want them to have as much support as possible?
So it's just what we wish all our children, that they become adults who are self-sufficient and self-sustaining. So we want them to be able to live in the world and be able to live on their own, take care of themselves. So how do we get them to do that? We have to get them to walk. We have to get them to talk. We have to get them to eat. We have to get them to learn. Now, they can learn differently. Learning is not A, B, C, D, and 1 plus 1. It can also be a skill set. They are very good at maybe doing masonry. They can be very good carpenters. They can be good tailors. What is their capacity? And then we support that capacity. They can be very good athletes. So how will they be well integrated into the society? Because that's all a parent wants. A child who is self-sustaining, who is well integrated in the society.
So what's the role of, say, physical therapist, occupational therapist, or speech therapist in the lives of these children and these families?
So we need them to, for each human being to move from point A to B, they need to walk. So we need an occupational therapist to get us to walk. Now, sometimes we may be able to walk without assistance or with assistance. So an occupational therapist, the word occupation means in my surrounding. How well can I move? Can I move with a wheelchair, or am I able to be assisted to move? Yeah. So for us to take care of ourselves, we have to move from point A to point B. We have to do self-hygiene. How do I brush my teeth? How do I go to shower? How to go into the ladies? All those things. That's what an occupational therapist does. Our muscles, because of our genetic makeup, might not be working at optimum. So what can I do in lieu of my muscles not working well? What assistance, what other gadgets can I use to get over this challenge?
Are our healthcare workers in Kenya adequately trained to detect or even just suspect that there is a genetic issue here, something happening, and at what point should they refer?
So I would say we are getting there. We've done a lot of awareness, so I'm getting a little bit more referrals in. You refer the moment you know you've reached your wit's end. If I don't know, then move to the next person. So if you've gotten a child and you're able to manage, when you get to the point where you are no longer offering service, at that point, please refer to the next person to offer better service. Yeah. So if you're not able to have a hard discussion about a trisomy or a chromosomal anomaly, let someone else who is able to have that conversation. Do not deny service. Actually, most of the time I see sometimes our colleagues denying service in the name of it is expensive. You understand? But you have not looked into the pockets of these parents.
You've not given them the option to decide for themselves that it's expensive or not.
Exactly. So have them have all the information. What they do with the information, but make sure they have the information. It is quite a different discussion when a patient comes in and tells me, I was informed at birth that my child would have a challenge, and we did a cardiac evaluation. We found a cardiac disease, which has been taken care of. We found a thyroid disease, which has been taken care of. However, I'm here to just know with finality what this is. That's a very good discussion, because this mother is tuned in. Instead of having a mother who's been carrying her baby around, who can't walk, who can't talk for the last 6 years. And then I tell her, if we found this baby at 1 month, we should be in school.
Walking or even in school.
Exactly. Yeah. So let's just have that high index of suspicion. Let's say I have had patients who we call negative patients. They come, we look, we tell them, no, you're over-worrying, you're overthinking it. This is just within the normal. Let's have that conversation.
And discussions really, and having that information is important. But we live in a society where culture, religion, even just conversations within the family unit are really strong and can really influence parents and what they do. So what misconceptions or perceptions do people have when they are coming to you with these chromosomal anomalies?
One of the biggest one is that the mother caused it by being an elderly mother.
Advanced maternal age.
Exactly. The guilt that the women carry is astronomical. And that is actually a misconception. You understand? Or someone looked at me badly or touched me badly.
When I was pregnant.
I had a patient who had an in-house priest who held her tummy and prayed for the pregnancy not to leave the tummy. Yeah, that bad. There was a pastor on pay
To pray for the
to
pregnancy.
pray for the pregnancy. So, yeah, there are deep issues. And they're being prayed. You're touching the woman. Nobody's ever looking at the man. Yes. And I have men who have moved from one lady to another with the same results. So those family discussions, they're very, very hard.
They're difficult.
They're difficult to have. And then the other thing is we do not have a social setup, and this, I mean the health system setup, that actually gives us and guides us on the referral pathway for these children, where they need to go. I mean, when I'm talking about children who have aneuploidy, we work very closely with the cardiac people, the pediatric cardiologists. You've heard about a lot of cardiac camps in Kenya.
Yeah.
Everybody's having a cardiac camp with interventional cardiologists coming into the country to close some of these holes. But why aren't we asking ourselves, why aren't we picking this?
What caused it?
Or what caused it? And do we need to correct it if we can prevent it? So we need to have that conversation backwards so that we are not excited about the first club. We are more excited about the first 100 women who have gotten genetic screening or neonatal screening, and we are sure that our kids are fine.
Are doing well.
Yes.
So how do we navigate these cultural and, religious beliefs, especially when there's finger pointing? Like you said, the woman is blamed. There's a lot of shame and a lot of,
inadequacies.
Yeah, and now you get shunned. And even you've said a man would be told, this woman is not good, look for another one because A, B, C, and D. How do we navigate this so that, the women are not the ones carrying the burden, yet a child is a product of two sets of DNA?
I think we did a very good job in the HIV world by having conversations. So we have to start having conversations. And I think one of the reasons we are motivated to have these conversations in Willow is because of this. We need to start having these open conversations that it is a disorder like any other disorder. Nobody is perfect. And when something perfect happens, we need to come together and work on it together. So having conversation, and it's not going to be a switch on, switch off. So we have to keep on having conversations and moving the conversations one notch higher, one notch higher. The same thing with the cost of testing. I hope Christine told you it was expensive to do just that one test. Yeah. And I remember she talked to me at a double-digit figure on how much she paid for a karyotype. When I came in, the karyotypes were retailing around 35, 40, 50,000. A karyotype should not retail for more than 10,000 Kenya shillings. And that's because we are sending it out. If we get capacity to do it locally, we can do it for less. So it's a question of having conversations, continuous conversations. Don't tire. Just continue.
Yeah. So these decisions really weigh heavily, not just on the parents, but also on you as a doctor. How do you navigate the ethical dilemmas? And by here I mean, when this the pregnancy will not be viable after birth, or that it's best, say, for a family to look for a donor egg or sperm, or even adopt and not, get their own pregnancies in future. How do you navigate this with those families?
So in another life, I'm an ethicist, meaning I know a lot about ethics and in the principles of ethics, autonomy, beneficence, non-maleficence, and all that. So the most important thing in this discussion, when I'm having that discussion, is patient autonomy and beneficence. What's the most beneficence with this couple, with this family get from the treatment I am offering? What is the autonomy? Have I been able to give space for the couple to decide as individuals? So autonomy is key. So the ethical dilemmas I face are actually very practical. I'll tell you. I know some disorders are maternally transmitted, and then a father decides to hide the baby from the mother, and they want me to test. I will not test you. It won't happen. It's unethical. it wasn't the mother's choice. It's not. And hiding this crucial information from her is not fair to her. Well, it's fair to the child to know the diagnosis. It's good for the father. He is the father. But really, what is the motivating factor in this diagnosis? You have to understand, what is the motivation for this diagnosis? Do you want to break up a family? Or do you want to keep them together? What is it? What's the best? What's the beneficence? Yeah, that's the benefit. And what's the non-maleficence? How will you not do harm? Do not do harm. This child is being taken care of by a mother and a father. If your diagnosis comes in and the mother or the father leaves the group, you have done harm. So you always, those are the ethical things. And sometimes it's not black and white. There's a lot of gray in between. But at the moment, you go with the principles.
So, and the patient autonomy really is important. So how do we improve early detection as a society? Is it by, providing information, not just to the patients, but also to the healthcare workers? Like, how do we make sure we get these things early?
So we need to start talking, and talking a lot. Yes, information is power. So the moment in fact, some of the patients who come to my clinic, I'm the one who is surprised because they've lived out there and they're walking into the clinic. I'm like, I am 8 weeks pregnant, I need my NIPT. I'm like, who referred you? No, nobody referred me, but I grew up abroad and I know I should get an NIPT at this time. So we need our patients so equipped that they don't rely on a doctor to say. They know, at this point, I need to have these tests. Yes. And that comes out of patient advocacy. It comes from buy-ins from not only the government, but also the patients themselves. Yes.
Are there any research developments or advancements around this chromosome 18 or the ring chromosome 18 so that there's better outcomes or, better management for patients with this condition?
Unfortunately, currently as we sit, the amount of genetic material chromosome 18 carries is a lot. And as we said, each one of them presents differently. So we do not have one pill that sorts it all out. It's individual to individual. And because we have a lot of information in chromosome 18, there isn't one management mode. So again, with chromosomal anomalies, there's so much. So we have a lot of management and treatment options for things we call single nucleotide disorders, but a chromosome is really carrying lots of genes, and each gene might be affected in one way or another. And really to understand, first of all, what has been affected, then create a treatment model, it's very hard. At the moment, again, caveat, at the moment, but things are working, things are being worked on. But right now in the genetic field or the genomics field, we are moving very fast with single nucleotide disorders. These big chromosomal disorders are still a challenge.
Okay. So if, say, somebody is watching you or is listening to you and they've just gotten a diagnosis of ring chromosome 18, what message do you want them to have today?
The baby is here. Let's do our best.
Let's do the best for the baby. Yes. Thank you. Thank you, Dr. Mutinda, for walking us through these unseen worlds of genes, unseen worlds of genetics. And, it's always a pleasure to get to learn a lot more. And you've helped us really understand how even rare conditions like ring chromosome 18 deserve visibility, empathy, and science-based care. For families or health professionals who want to learn more, follow us on Willow Health Media for more content like this on our YouTube, Spotify, and our social media platforms. You've been watching and listening to Willow Lifeline Dialogues Code of Life series with me, Dr. Mercy Korir. If this episode opened your mind or moved your heart, share it with someone who might need it. Until next time, keep asking, keep learning, and keep holding on to hope. Let's do our best. Thank you.